Well, good evening and welcome to this Holyrood Webinar. This is the first in a series of webinars organised for Scottish politicians and others to help deepen understanding of the issues involved with assisted suicide, euthanasia, and the potential future impacts of changing the law. I'm delighted this evening to welcome our first speaker. Professor Theo Boer is Professor of Healthcare Ethics in Groningen and has extensive experience in the ethics of euthanasia and assisted suicide. Between 2005 and 2014, he served on one of the 5 regional review committees on euthanasia, and so had a regulatory role of the legislation in the Netherlands. Now, when Theo has spoken, there will be a brief opportunity for a Q&A session with him because, unfortunately, he needs to leave us by about 7 p.m. So let me welcome you, Theo. Can I now invite you to go ahead, activate your microphone and so on, and begin your presentation? Thank you very much.
Thank you, David, for this warm welcome, and thank you for having me for this occasion, which is a really important occasion, I think. As you can see, I have shared my screen. I would like to speak about the laws of assisted dying, meaning not only legalizing assisted dying, but also what the laws of legalizing mean, namely the consequences they are about to have. Speaking from my experiences in the Netherlands, I have no commercial relationships whatsoever. What I will be doing, ladies and gentlemen, and let me again say that I'm very honored to be speaking here, and I hope all of you, I know all of you are very much concerned about, in one way or the other, about the theme. It's a theme that regards all of us, and that I can very much sympathize with all sides of the debate. But what I will do in this session is I will say something about how the law in the Netherlands functions, and we'll say something about the numbers and the reasons why people request euthanasia, and I will say something about what I see, what I consider to be the framing of the debate internationally, which is that if we do not legalize assisted dying, that we'll be actually causing a lot of suffering. Then I'll go over to asking what the developments in the Netherlands are, the most interesting developments, and I will conclude with some thoughts about what could happen in Scotland or in the United Kingdom when assisted dying is legalized. Now, to start with, and some of you may be familiar with this, but what is our euthanasia law? What does it mean? If you look at the bottom of this slide, you can see that the definition of euthanasia is the active killing of a patient at their request by a doctor. That is actually, we were the first country, I think, after World War II that started using or reusing the term euthanasia. And as you can see also at the bottom of this slide is that the term comprises in the Netherlands both euthanasia, which accounts for 97% of all the cases, and physician-assisted suicide, but there's only 3% of all cases consist of assisted suicide, which means that patients and their doctors together, if they are left the choice, they prefer the doctor to do the act, which I think is morally and medically very important. So when I'm speaking about euthanasia, it means that there is a small percentage of assisted suicide as well. Now, what are the criteria? The first is that there should be a medical diagnosis. Must be the basis of the suffering must be found in a grave medical condition. Secondly, there should be a patient request, which means that if there's no request, we don't talk about euthanasia. It's not in the definition. Thirdly, there should be unbearable suffering, and not only suffering, but unbearable suffering. And it should be without prospect of improvement, which means that that is a medical criterion. The physicians have together made sure that they have seen that there's no hope medically. And I should also add that there should not be an alternative way to ease the patient's suffering that is acceptable to the patient. That is an important thing. And then finally, there's an opt-out for individual doctors and for institutions. So unlike, for example, Canada and some Belgian institutions, there is no obligation to perform euthanasia. As you can see, those criteria, they seem to be, and they are referred to be as strict, but they are not really. A medical diagnosis, of course, is always present. As you will see after this slide, a patient request is always present, but even in an advance directive. What is unbearable suffering? Well, that very much depends on the patient and is up to the patient to decide, because it is very, very hard for a doctor to say, well, I don't think that you are suffering unbearably, or I don't think you are suffering enough. So this principle of unbearable suffering in effect means that the patient insists on having euthanasia, and the doctor will have to assume that this is because the suffering is unbearable. Then not included, that's important. There are some criteria that have partly been into consideration, but they are not in place. And that is there's no information or consultation of the relative, which means that cases occur where the relatives are devastated. That the patient dies. And I know of several people who were called by a physician, and the physician said to them, "We are sorry to have to inform you that your mother died last night." So that was because not including asking the relatives was because originally we thought that it would not be wise to, that it would be important that the patient would take their decision all alone. Secondly, there's no foreseeable death or terminal illness inclusion, which means that in several other countries that is a part of the euthanasia law, but not in the Netherlands. Thirdly, there's no doctor-patient relationship required. Fourthly, the patient is not required to be conscious when the moment of the killing is there. So that means that we have cases where the patient is killed on the basis of an advance directive. And fifthly, there's not the criterion that the patient should perform the acts preferably themselves. Now, as for the numbers, as you can see here, the numbers in 2001, it was legalized, and we already had before 2000, we had a euthanasia practice, but it was under a makeshift law. But as you can see, under the first 5 to 6 years, really the numbers remained level, and we all thought that this was the proof that the Dutch euthanasia law worked, that it helped us to make an existing practice transparent. And we were actually very happy about these numbers. If you also consider that this is the number of reported cases, but in the first years of this century, the number of non-reported cases went down, which means that the total number of cases went down, and the percentage of reported cases increased from 50% to about 80%. So we were very happy that this law did work. But then as of about 2006, the numbers went up, and I was part of one of the review committees under those years. So we first thought that, that can happen, and maybe it has to do with an increase in the total mortality in the Netherlands. But actually, that wasn't the case, because the total mortality is about stable at 140,000 or 150,000 per year. So, and as you can see, the numbers continue to rise. And with a dip, as you can see, in 2017, and that was because of a number of procedures of a court case even, where doctors became hesitant and they thought we are not safe anymore. But after, as you can see, the numbers have risen since 2018 again. So now about 7,000, and actually the expectation is that this 2020 number will be trumped in 2021. Then this is interesting for you also. You can see that what is the medical background of the patient? Well, in 2002, as you can see, the big part was blue, which is cancer, and then there were some other mostly physical diseases. And as you can see in 2019, actually I have not put together the 2020 numbers, but as you can see in 2019, the great majority still is cancer, but a number of other illnesses came to it. And most notably, and not very many, but still a total of about 500, that is age-related diseases, dementia, and psychiatry, which means, and that is important, those are not people who are afraid of a terrible death, but those are people afraid of living. So from being a last resort to prevent a terrible death, euthanasia is increasingly becoming a last resort to prevent a terrible life, and that even applies to the terminal patients, because the palliative care has become so much better in the past 20 years in the Netherlands that pain is hardly any more the primary reason. It is the other things like care dependence, meaninglessness, in part also loneliness, that form the basic reasons behind the euthanasia request. And these reasons continue to shift. This is an interesting slide because with my assistant, we did research about the regional variation, which means that it provides some insight in how it can be that 4.5% of all deaths in the Netherlands are preceded by euthanasia, 4.5%. But as you can see, there are regions where that percentage is lower, and there are regions where it is higher, and especially the province of North Holland, which is the province where Amsterdam is. It has about double the numbers of the province of South Holland, which is Rotterdam. The city of Rotterdam has exactly half of the numbers of Amsterdam. There are some neighborhoods in Amsterdam, in and around Amsterdam, where now 1 in 7 deaths is the consequence of assisted dying. So that means that there is, in the course of the coming years, probably a growth potential in the rest of the country, as we have witnessed that some regions that were low incidence regions have now also reached higher numbers. So it is like a film. It's like a movie that plays not in 1 or 2 years. It plays in 20 to 40 years, really. Now, something about the framing, and this slide, you can see it. I just took it from the British site, Dignity in Dying, where it says that 70 people a day will suffer as they die, and it has, interestingly, this disclaimer on their website that we have to be aware that the coming web pages that we will click on will provide us with terrible history, terrible stories of terrible suffering, which means that basically I think they are scaremongering us, and they're warning us. Now, what is this warning worth? Firstly, and I made, just as not being an empirical scholar, so I may have made a mistake here, but In the UK, every day about 1,900 people die. So 17 people a day is 0.8%, which I think means that 99.2% do not suffer when they die, if that is correct, at least, which is good news for the 1,883 people a day who die without suffering. So actually, that number is good news. But secondly, dignity in dying uses the term suffer. They will suffer as they die. And now the Dutch law says that they should suffer unbearably. You know, all of us suffer occasionally. So I wonder what is meant precisely by the term suffering. Because some suffering, not unbearable suffering, hopefully, but some suffering is part of human life. I always say life should not be enjoyed, life should be lived, and that includes maybe including some suffering. However, don't mistake me on this. I think we should further insist on further improving the palliative care for those who are suffering. No doubt about that. But why is this 70 people a day? Why is it a reason to legalize assisted dying rather than insisting that we will try to improve the conditions of those 70? Now I come to some of the developments in the Netherlands, because they, I think that even though Scotland is a different country than the Netherlands and the UK is, it may be that these developments may be a kind of a mirror where you can see yourself in 2050 or 2040. Now, the first is that we have this expertise center, euthanasia, which used to be called the End of Life Clinic, but they changed their name 2 years ago, where for the first time in Dutch history, people could get euthanasia without there being a prior doctor-patient relationship. And I spoke to their director in 2014, and he said, in 2018, we want to have made ourselves redundant, because by then the doctors in all over the country will have learned how to do it. And the contrary is true. They have made themselves central in the Dutch euthanasia practice, helping about 1,000 people die a year with a growing tendency, and many of these are people with dementia and psychiatry. About 1,000, which I think is about 1 in 7 deaths in 2020. Then there's, you know, if you look at some other countries, and this is Oregon, for example, there's an assisted suicide law, of course. Now, first of all, what they have removed is the 15 days to live, the waiting period for those people. And secondly, I think what is more important is that there's a growing advocacy for euthanasia for those who can no longer swallow or who dare not kill themselves, and who are better off when a doctor does it. Actually, ladies and gentlemen, the logic behind liberalization will and always will be, it is that there is some injustice when you legalize the one, there will be some injustice to others. I was myself part of an expert panel in Canada, where the Canadian euthanasia law that was introduced in 2016 was part of a court case where it was called the Gladue and Truchon cases, where people that had no terminal disease demanded that this same law that granted terminal patients euthanasia would also apply to them. And actually, although I warned them, if I may say that so bluntly, but the court in Quebec decided that it would be accessible for anyone in severe suffering, no matter what their life expectancy would be. And then Justin Trudeau decided that this court case, this verdict, would be applicable to to all of Canada without any appeal. Another part is that we had an acquittal in 2020, April, where one of our physicians who killed a patient who was in an advanced stage of dementia. He killed her, who she resisted during the euthanasia. She had an advance directive in which she said that if she were in this position, she would require euthanasia, she would have it. And the High Court, the Supreme Court, said that this is actually the good thing to do. They acquitted the doctor, and they said that that if a patient has an advance directive, under certain circumstances, the physician does not need to ask the patient for their consent because they have a written consent. This is about the same case. And then just a year ago, the government decided that from euthanasia would also be for children under 12 years. And it hasn't been practiced yet because as I understand, the Dutch prosecutor's office has some problems with this decision of the government, but I'm not sure of that. Euthanasia for two, which means that one partner is terminally ill and the other patient is care dependent upon the terminally ill partner. It happens 1 to 2 dozens times a year with an increasing tendency. And then, of course, as you may all know, we are on our way to legalize assisted suicide from completed lives. I said we are on our way to legalize it, but I have some hope that prudence will prevail. Actually, an increasing number of people think that this goes too far. So what could happen, and I have to look at the time, and we'll be finished timely. What could happen when legal assisted dying? Well, it will not be 17 a day, and of course I'm not talking about Great Britain and not about Scotland, but it will definitely not be 17 a day, and based on the Dutch numbers, momentarily, it might be 30,000 a year or more in the UK. Secondly, and that is the logic that I was referring to, some people will find themselves discriminated against. So why only terminally ill patients and not people with a longer life expectancy? After all, their suffering may be much harder because they have no horizon to look forward to. They have maybe a life expectancy of months or years or decades. Thirdly, why only physically ill patients, whereas people with psychiatric illnesses may suffer much harder? And I think actually, frankly, I think they do. And I think psychiatry and euthanasia is for me one of the hardest and most heartbreaking cases, and not terminally ill cancer patients. However hard it may be for them too, don't misunderstand me. And then fourthly, why only competent adults and not people with advanced directives, which has happened in the Netherlands also. And then why only people with an advanced directive and not small children whose parents can require an assisted death by proxy? Well, and the sixth is also the completed life. And so all 5 expansions have indeed occurred in the Netherlands. So my conclusion is that the Dutch example testifies that once assisted dying is legal, this will change our views of dying, of suffering, of vulnerability and care dependence. It will change all our views. And I compare it to the way flying has changed tourism, friendships, politics, and the economy. Even for those who do not fly, the option to fly is there. So the option to die by active means poses a question to any suffering patient nowadays in the Netherlands. And it is called the distress of the choice. Should I or should I not use the option to end my life? Secondly, and lastly, if there's any period in the history of humankind in which assisted suicide was less necessary to prevent a terrible death, it is in the years 2021 and further. Thank you, and maybe there's time for just a couple of questions. David?
Good. Theo, thank you very much for that. Very insightful. You won't be surprised to learn that we've got a load of questions coming in. We won't have time to ask you all of them. We've got questions about medication, about the effect on doctors, about policy details. But let me just ask you a couple of things about the points you highlighted concerning the specific Dutch experience. So you showed a graph indicating, or you showed a map at least, of regional variation. So some folks are asking, well, do you have any idea about the individual demographics there? Is this related to socioeconomic status or age, or do you have that kind of background information? That's the first element of that.
Yes, thank you, David, for that question. Oh, thank you for the question asker. That is, of course, what we researched, and you can find, if you type my name and British Medical Journal support and palliative care, you will find the full article. What we of course did was we tried to find the reasons, and we found clear relationships with religion and with political views, and we found a clear relationship with the availability of a good social network. All those were in clear relationship to the numbers of euthanasia. However, there remained still an important factor. About half of this variation was not explainable, not yet. So we will do interviews now, and we'll go into the regions and ask doctors why it happens in this region and why it doesn't happen elsewhere.
Okay, and maybe if I have time, just again specifically on your Dutch experience, you showed a graph indicating the prevalence of euthanasia dipping a couple of years ago, about 2017, I think you said.
Yes.
And you indicated that there was a sense in which the doctors involved perhaps felt unsafe. Is it easy for you to encapsulate the reason for that in a matter of a few sentences? I'm just anxious not to detain you longer than your deadline, but
yes, I know. I think, David, there were two reasons, and one of them is that in a couple of years earlier, but that was a thing that cast the long shadow, was that one doctor had killed their patient without requests, and but very terminally ill, and this doctor was actually put in jail and committed suicide. Or not put in jail, but there was the police were on his doorstep, and he committed suicide, and that's the first case. Heartbreaking, really. And the other one was the euthanasia of a dementia patient that I referred to, that the High Court acquitted just a year ago. And that case was in 2016, 2017, very much in the news. So the general feeling of the public was, if you do euthanasia, you might be in big trouble, which was not true, but because these were groundbreaking cases, not the normal cases.
Theo, thank you very much. We've actually got some other questions about the effect on doctors, but I think we'll hold these for now and perhaps direct them elsewhere. So Theo, thank you. I realize you've got other meetings to get to, but yes. Thank you for your contribution. We're very grateful that you've been able to join us this evening, and so thank you very much, and we wish you well.
Thank you, and thank you all best to all of you, and especially to those of you, of course, who have to make decision in this field, and wish you all the best, and thank you for having me.
Good, great.
Bye.